Hello, I'm Dr. Anthony Wheeler, and I'm telling you everything that you need to know about pathology. Now, you're probably looking at this image saying, oh, I know what each and every one of these arrows are pointing to, right? This is basic anatomy. We're going to be discussing breast pathology in this presentation. This is covered in your book, Medical School Pathology and Step 1 Review. You can scan the QR code to get to the updated material. Breast pathology. Now, as you know, the breast is essentially a modified sweat gland. You'll be asked that. And it's embryologically derived from the skin. This cartoon depicts some particular anatomy from the breast that you should be aware of. Possibly all of these things, but for sure you should be able to point out the ducts and the nipple, the areola, skin, etc. Now, the milk line, that extends from the axilla to the vulva, is a region along which breast tissue can form anywhere. You remember that from embryology, right? The milk line. The functional component of the breast is the terminal duct lobular unit. The terminal duct lobular unit consists of important things, which include the lobules that produce milk and the ducts that allow milk to drain to the nipples. And you know that the luminal cell layer and the myoepithelial cell layer are the two layers of epithelium that line lobules and ducts. That's important from a histological standpoint. The inner layer of cells that lines the ducts and lobules is called the luminal cell layer. The luminal cell layer within the lobules is responsible for milk production. The myoepithelial cell layer, on the other hand, is the outer cell layer lining ducts and lobules. Contractile function propels milk towards the nipple, knowing the fact that the breast tissue is hormone sensitive. Male and female breast tissue before puberty mostly consists of large ducts under the nipple. After menarche, estrogen and progesterone are principally responsible for development, with lobule formation and tiny duct density being highest in the upper outer quadrant. Especially before menstruation, breast tenderness during the menstrual cycle is a common complaint. And you know that the breast lobules go through hyperplasia. You remember that? Hyperplasia, which is a growth in cell count, right? You remember what hypertrophy is, right? Size, or well, hyperplasia is count, right? You'll be asked that. Now, when this hyperplasia occurs in an organ or tissue, there's an increased cell count. And with the breast, this most often is experienced during pregnancy. Estrogen and progesterone produced by the corpus are what cause hyperplasia. The luteum, or early first trimester, fetus, and placenta, and later in the pregnancy, like after menopause, breast tissue undergoes atrophy. Galactorrhea is the term for milk production that happens outside of normal lactation. Causes of galactorrhea include drugs, nipple stimulation, and prolactinoma, which usually shows up somewhere in a question set or in vignettes. Prolactinoma, where? Of the anterior pituitary, right? And here we can see a picture from a breast specimen that was removed from a patient, showcasing invasive ductal carcinoma. This is what it looks like grossly. And here we have the microscopic image from a histologic sample that had ductal carcinoma in situ. Notice all the small cribriform glands. Now let's talk about inflammatory breast conditions. Do you know any? How about acute mastitis, which is the rapid inflammation of the breast? As you can see here to the right, you see that erythematous area? This mastitis is localized to the underside of the breast. Look at that large area of inflammation. And as you know, acute mastitis is often due to a bacterial infection. That means what type of cell infiltrate will be present, neutrophils or lymphocytes? Typically neutrophils, right? Staphylococcus aureus is a common cause of acute mastitis. Acute mastitis is related to breastfeeding, right? So mama's taking care of a little baby, little 1-month-old baby, and the nipple develops fissures that give microbes a way in. Symptoms of acute mastitis include a purulent nipple discharge, erythematous breast, like we just saw in the previous image, and even an abscess formation. What type of cells are usually present with abscess? Neutrophils or lymphocytes? Neutrophils, right? Polymorphonuclear cells, right? Now, how do you treat acute mastitis? With antibiotics. And drainage may be necessary if an abscess has formed. So you future surgeons, be on the lookout for this. On imaging, we can see this ultrasound showcasing mastitis. And we can see the histologic specimen from a patient that has mastitis. Note all the neutrophils in the background. Now let's talk about periductal mastitis specifically. This is mastitis in the subareolar duct area, right? Periductal mastitis is subareolar duct inflammation. And squamous metaplasia of lactiferous ducts is caused by a relative vitamin A deficiency, which causes duct blockage and inflammation. Periductal mastitis is commonly detected in smokers, right? Just another reason not to pick up the nicotine. Clinical signs of periductal mastitis include subareolar mass, right? You might pick that up on a physical exam. And retracted nipples. Also, you should be able to notice that on a physical examination. Now let's talk about another entity that you must be aware of, called mammary duct ectasia. What's mammary duct ectasia? Mammary duct ectasia is a rare condition where there is inflammation with dilation of the subareolar ducts. And FYI, ectasia, for all intents and purposes, is a synonym for dilation. Now, this imaging to the right here shows mammography with liponecrosis and plasma cell mastitis with typical rod-like calcifications. Can you see all the calcifications? Now, mammary duct ectasia typically occurs in post-menopausal women who are multiparous. What does multiparous mean? Multiparous means, I believe, had many children or many pregnancies. You future OB-GYNs, let me know. Figure out a way to let me know and share your information. Mammary duct ectasia presents as a periareolar mass with green-brown nipple discharge, that inflammatory debris. And histology of mammary duct ectasia reveals chronic inflammation with plasma cells. Do you remember what plasma cells look like? Because you might be asked to visualize this on histology. They have that eccentric nuclei and the perinuclear Hoff, right? Now here we have mammary duct ectasia. What can you tell about the nipple? It's inverted, right? Look at your physical exam skills. Excellent work. Now, fat necrosis. This shows up a lot. Fat necrosis is a benign, non-cancerous disorder, most frequently present after a trauma or injury to adipose tissue. And as you know, the breast has a lot of adipose tissue, which is why we're talking about it in this section. Well, look at that. Everything comes around. To the right here, we can see a histologic sample showcasing a biopsy from a breast lump showing fat necrosis. Note the shadowy outlines and the necrotic adipocytes. This is fat necrosis classic. Although a history of trauma may not always be obvious, fat necrosis is typically linked to some sort of trauma. So make sure you have a thorough history or tease out those vignettes that might not be so direct. Fat necrosis typically manifests as a mass during a physical examination or calcification during a mammogram due to the process of saponification. You might have heard that word before. It's a process utilized to make soap. Interesting. Now, the histology of fat necrosis typically shows necrotic fat with accompanying calcifications and enormous cells. Now, what about fibrocystic changes? You'll probably hear that. Fibrocystic changes are the development of fibrosis and cysts, fibrocystic, in the breast. This cartoon here tries to showcase the fibrous growth that may be present with fibrocystic changes. The most common change in the perimenopausal breast is fibrocystic change. And this is assumed to be due to hormones. Fibrocystic change may manifest as a vague, irregular lump, right? So you might have a patient that's concerned. They were in the shower and they felt a lump. If it turns out to be fibrocystic changes, you can deliver that great news and be the superhero that you are. Now, in regards to fibrocystic changes, both breasts are affected by benign changes. However, some fibrocystic related changes are linked to an elevated risk for invasive cancer. To the right here, we have an FNA, fine needle aspiration, specimen that has been pap stained, showcasing fibrocystic changes of the breast. And in regards to fibrocystic changes, no increased risks are shown by fibrosis, cysts, or apocrine metaplasia. Sclerosing adenosis and ductal hyperplasia both indicate greater risk of progression to malignancy. And here we have some histology showcasing fibrocystic changes. Now let's talk about intraductal papilloma. Intraductal papillomas are wart-like tumors that grow within the milk ducts of the breast. As you can see here on this ultrasound showcasing an intraductal papilloma. Intraductal papillomas are benign. Isn't that lovely? And intraductal papillomas are distinguished by the presence of fibrovascular projections lined by epithelial and myoepithelial cells. To the right here, we can see the histopathology of an intraductal papilloma. The stain, that brown, golden brown stain you see there, is picking up on the alpha smooth muscle, or on the smooth muscle. In a premenopausal woman, intraductal papillomas typically manifest as bloody nipple discharge. Intraductal papillomas must be distinguished from papillary carcinoma, which represents bloody nipple discharge. On histology, papillary carcinoma has fibrovascular projections lined by epithelial cells but lacking underlying myoepithelial cells. As you can see here in this histology from an intraductal papilloma of the breast, and note the risk of papillary carcinoma increases with age. And here we have histology showcasing immunostaining for P63 protein of an intraductal papilloma. Now, this is very important. Everybody should know what this is. It's a fibroadenoma. In the image here, we can see it on ultrasound. Now, fibroadenomas, this is going to show up again and again and again on vignettes and in real life. A fibroadenoma is a solid breast mass made up of fibrous tissue and glands. Fibroadenomas are benign, and they are the most common benign breast tumor. Fibroadenomas commonly affect young women. So you might see a 20, 30-year-old female come into your clinic or be presented on a vignette saying, I was in the shower, felt a lump, I'm concerned, do I have cancer? Highly likely it's a fibroadenoma. But you will need biopsy and to have a pathologist look at it. Fibroadenomas present as a well-circumscribed, mobile, marble-like mass. Additionally, fibroadenomas are estrogen sensitive. And what does that mean? That causes them to grow during pregnancy and be uncomfortable in certain phases of the menstrual cycle. Here we have an ultrasound image of a fibroadenoma. And here we have histology of a fibroadenoma. And here we have an FNA of fibroadenoma. And now we have an FNA that's been stained, highlighting these abundant bare bipolar stromal nuclei surrounded by sheets of metachromatic epithelial cells, characteristic of a fibroadenoma. What's this histology? You see all the fibrous tissue, you see the ducts that are just compressed and pushed together. This is the intracanalicular morphology of a fibroadenoma. What's this? Mass that's been removed from a patient, put in formalin, I presume. It's very fibrous, very well circumscribed. Could this be the macroscopic view of a fibroadenoma? What's this? Fibroadenoma. See, knowing what a fibroadenoma looks like is very, very, very important because you're going to see it. But you must be able to distinguish it, definitely, from a phylloides tumor. Now, a phylloides tumor is a tumor with an overgrowth of the fibrous component that resembles a fibroadenoma. The histology of phylloides tumor shows buzzword leaf-like projections. Leaf-like projections. From a breast biopsy, think phylloides tumor. Phylloides tumor is most frequently observed in post-menopausal women. And in some very rare instances, phylloides tumor may become malignant. Here we have a mammogram showcasing a phylloides tumor. And here we have histology showcasing the leaf-like pattern of phylloides tumor. And more histology showcasing phylloides tumor. And more histology showcasing phylloides tumor. Now let's talk about a very concerning entity, very common entity, breast cancer. Breast cancer is the most common variety of carcinoma in women, excluding skin cancer. Breast cancer is the second most common cause of cancer mortality in women. Risk factors for breast cancer include BRCA mutations, familial history of breast cancer, increased estrogen exposure, early menarche, late menopause, right? It's all about that exposure to estrogen, and obesity for the same reason. There's more estrogen due to the increased adipose tissue. The types of breast tumors that you should definitely know about include ductal carcinoma in situ, invasive ductal carcinoma, lobular carcinoma in situ, and invasive lobular carcinoma. Here we have a number of scans showcasing breast cancer and the metastasis to the right scapula. And here we have a number of histologic sections showcasing breast carcinoma compared to normal breast tissue. And here we have a micrograph showing a lymph node that's been invaded by ductal breast carcinoma. Can you notice the difference between the blue areas and the pink areas? That's probably a little too vague. How about this? Right in the center there, you see a bunch of small blue cells. And if you look at their overall architecture, it somewhat resembles an oval, right? You see that near the center? And to the left of center, you see some amphiphilic cells. That shouldn't be in a lymph node, right? This is metastatic cancer. And here we can see a histologic section from a breast cancer. Note the minimal tubal formation and the varying sizes, and even the mitotic figures. And here we have breast cancer that was removed from a patient. This is what a lumpectomy looks like in real life. And here, for you future radiologists out there, is what an MRI looks like that's showcasing breast cancer in this particular case. And this is a very special imaging technique showcasing a breast CT with a tumor that's being visualized. And this is a breast cancer that has inverted the nipple. And here we have a mammogram showcasing a normal breast on the left compared to a breast with cancer on the right. See where that arrow is pointing? Now, ductal carcinoma in situ. What is that? Ductal carcinoma in situ, or DCIS, is the term for malignant ductal cell growth that does not involve basement membrane invasion. To the right here, we can see a histopathologic image showcasing ductal cell carcinoma in situ. Notice how the basement membrane has not been invaded. Although ductal carcinoma in situ often shows up as calcification on mammography, it rarely results in a malignancy. Mammographic calcifications can also be associated with benign disorders such as fat necrosis, sclerosing adenosis, and fibrocystic changes. Biopsy of calcifications is often necessary to distinguish between benign and malignant conditions. The comedo type of ductal carcinoma in situ is distinguished by high-grade cells with necrosis and dystrophic calcification in the core of ducts, whereas histologic subgroups of DCIS are based on architectural features. Ductal carcinoma in situ that spreads up the ducts to affect the skin of the nipple is called Paget disease of the breast. Paget disease of the breast presents as nipple ulceration and erythema. There is nearly always an underlying carcinoma present when Paget disease of the breast develops. Here we can see immunohistochemistry with calponin and ductal carcinoma in situ. And this calponin is highlighting myoepithelial cells around all tumor cells, thereby ruling out invasive ductal carcinoma. Ductal carcinoma in situ, again, we have this histopathology. In this particular case, the cribriform type of breast ductal carcinoma in situ. And here we have various representations of ductal carcinoma, some with necrosis, like in D, right? In the center-ish there, that necrotic tissue is necrosis. Now let's talk about invasive ductal carcinoma. Invasive ductal carcinoma develops when duct lining cells transform and spread into surrounding breast tissue. Invasive ductal carcinoma is the most common type of breast cancer. Invasive ductal carcinoma may be detected by physical examination or mammography. Mammographically identified masses are often 1 centimeter or greater, while masses found by physical exam are typically 2 centimeters or greater. Skin dimpling or nipple retraction are possible side effects of advanced invasive ductal carcinoma. And here we can see the histology of invasive ductal carcinoma of the breast. The histology of invasive ductal carcinoma shows haphazardous ductal cells in a desmoplastic stroma. The prognosis of invasive ductal carcinoma is good if it is caught and treated early. Other types of breast cancers to have some familiarity with include tubular carcinoma, mucinous carcinoma, medullary carcinoma, and inflammatory carcinoma. Tubular carcinoma is like invasive ductal carcinoma, but has slightly more tapered and pointed end glands, right? It'll look a bit more spindly. The lack of myoepithelial cells and well-differentiated tubules is a characteristic of tubular cancer. In regards to mucinous carcinoma, that is characterized by carcinoma with abundant extracellular mucin, hence mucinous carcinoma. There's abundant extracellular mucin, where tumor cells are floating in a mucus pool. Medullary carcinoma shows large, high-grade cells developing in sheets and accompanied by lymphocytes and plasma cells. Inflammatory carcinoma manifests as swollen, inflamed breast tissue with no apparent lump due to tumor cells blocking lymphatic drainage. And here we can see invasive ductal carcinoma of the breast on histology. And here we can see the histopathology of invasive ductal carcinoma of the breast representing a serous growth. And again, we can see infiltrating ductal carcinoma of the breast assayed with anti-HER2 antibody. And here we can see invasive ductal carcinoma of the breast assayed with anti-mucin 1 antibody. And this is what invasive ductal carcinoma looks like grossly. And this is a mastectomy specimen that contained a very large invasive ductal carcinoma of the breast. Now, lobular carcinoma in situ. Lobular carcinoma in situ consists of lobules with malignant cell growth, but no invasion of the basement membrane. Lobular carcinoma in situ is normally discovered by accident during a biopsy because it does not result in a mass or calcifications. The histology of lobular carcinoma in situ is characterized by discohesive cells lacking E-cadherin adhesion protein and is often multifocal and bilateral. Tamoxifen is used as treatment to lower the chance of developing subsequent carcinoid and, in addition, a close follow-up low risk of progression to invasive carcinoma. Now here we can see a diagram showing lobular carcinoma in situ compared to invasive cancer. This is a very important distinction to make, so make sure it's clear in your mind's eye. And here we have a number of representative photomicrographs of lobular carcinoma in situ, ductal carcinoma in situ, and invasive cancer triplet. Now, invasive lobular carcinoma. An invasive carcinoma that typically develops in a single file manner and may have cells with signet ring morphology is referred to as invasive lobular carcinoma. Now, if you look in the center of this image here, can you see some cells lining up in the single file line for the most part? Note the single file cells and cell nests are indicative of invasive lobular carcinoma. And if you kind of glance around this image, you'll see a lot of cells that are lining up in single file patterns for the most part, right? There's no duct formation is found in the areas involved by invasive lobular carcinoma due to a lack of E-cadherin, right? There's that lack of E-cadherin, right? And here we have the histopathology of invasive lobular carcinoma next to lobular carcinoma in situ, right? Can you see the differences? And here we can see histopathology of pleomorphic invasive lobular carcinoma, partially consisting of plasmacytoid cells, right? Unlikely that you'll be asked this, but make sure you can recognize that single file lining of the invasive lobular carcinoma cells. And here we can see classic invasive lobular carcinoma of the breast on H&E. Now, I know it's a bit vague and not very well stained, but can you see the cells lining up in single file lines? I surely hope so. That is invasive lobular carcinoma. Now, there are certain prognostic factors of breast cancer. The TNM staging system, which I'm sure you're aware of, I hope so. That T stands for tumor, N stands for nodes, and M stands for metastasis. And that can help determine the prognosis for breast cancer. Although metastasis is the most crucial element, most patients show up before metastasis happens. Given that metastasis is uncommon at presentation, spread to axillary lymph nodes is the most helpful prognostic marker. With sentinel lymph node biopsy, axillary lymph nodes can be assessed for malignant cells. The most important factors that help determine treatment and prognosis for breast cancer include estrogen receptor status, progesterone receptor status, and HER2 new gene amplification status, right? ER/PR HER2 new. Both estrogen receptor and progesterone receptor are found in the nucleus, and their existence is linked to a response to anti-estrogenic drugs like tamoxifen. Response to trastuzumab, aka Herceptin, a synthetic antibody targeting the HER2 receptor, is linked to HER2 new amplification. So if you see HER2 new amplified on your reports that you get back from pathology, you can utilize Herceptin for all intents and purposes. On the cell surface, there is a growth factor receptor called HER2 new, right? The prognosis is poor for triple negative cancers, which are for ER, PR, and HER2 negative. So if all of those are negative, it's called triple negative, and the prognosis is poor. Triple negative carcinoma is more likely to develop in African American women. Hereditary breast cancer accounts for 10% of all cases of breast cancer. In regards to hereditary breast cancer, several first-degree relatives with breast cancer, a tumor at an early age during premenopausal states, and multiple tumors in a single patient are clinical characteristics that suggest hereditary breast cancer. The most significant single gene mutations linked to hereditary breast cancer are BRCA1 and BRCA2. BRCA1 and BRCA2, BRCA1 and BRCA2. You will definitely be asked about those. Breast and ovarian cancer are both linked to BRCA1 mutations, whereas BRCA2 mutation is linked to male breast cancer as well. Bilateral mastectomy, which involves removing both breasts surgically, is an option for women who have a genetic predisposition to breast cancer in order to reduce the risk of getting carcinoma. Now let's talk about male breast cancer. Male breast cancer patients make up just 1% of the total breast cancer population. Male breast cancer usually presents as a subareolar mass in older males. Males have the highest density of breast tissue beneath the nipple, which has the potential to produce a discharge, even in men. Invasive ductal carcinoma is the most prevalent subtype of invasive breast cancer in men. Lobular carcinoma is rare in males because the male breast develops very few lobules. Risk factors for male breast cancer include BRCA2 mutations and Klinefelter syndrome, in which males have an extra X chromosome. And with that, you've completed a very important presentation. Applause to you. You're doing such a great job, making me very proud. You're just cruising. You're doing so well. You're going to kill it. Keep up the good work, and I'll see you later.